So I should upload my slides. Like it's 2 minutes.
Evening.
Hi, Uma ma'am.
Hello.
I hope to see you all in October at the AICC RCOG.
Absolutely. Yeah, I'm planning to come.
Thank you.
Thank you for the invitation. Thank you.
So next week we will send the emails with everybody's involvement and the registration link. I just request everyone to register.
Sure.
Early bird we have extended till the 15th.
Okay, fine.
We have a
Hi,
good
Dr.
rest.
Umaji.
Good afternoon.
Good afternoon. How are you?
Good evening, sorry.
Oh, well, I mean, when you're sitting in your office, you don't know whether it's morning, evening, or night
I
because
come
the
home.
lights and ACs are on all the
Yes.
time, unless you open the window.
And
Hello,
Archana
Dr. Srimati ma'am.
was not 24.
Good evening, ma'am.
Evening.
Good
I'm
evening.
Srimati from Bangalore.
Nice, nice.
Thank
I
you.
think these webinars have connected, isn't it, Purnima, to north, south, east, west
Yes.
on this platform focus. I think Anjum has really Anjum and अपना आज
Rupali
नहीं
has
है क्या हमारे
Rupali
Anjum.
has convener nahi hai, but she has helped me a lot.
I know.
Backstage.
Anjum, Rupali, Manila, I think they have taken such a big this thing, no task in their hand and connected us to all over the country with all RCOG members. So thank you so much. So shall we start? It's 1 minute is remaining.
Yes.
So we start on time.
I have sent reminder to Mahesh Gupta sir and to join. Maybe they'll be joining soon.
And then one.
Manila ma'am has not joined yet, I think.
Okay.
And Dr. Dhwani is the MOC today. She has joined. Welcome, Dr. Dhwani.
Good evening. Good
Hi.
evening, ma'am. Good evening, dear seniors.
Hi,
I'm quite.
Dhwani.
Hi, ma'am. It's nice to finally, be a part of this. I've been waiting for a long time.
So Dr. Nuzhat, she's from Hyderabad for
Yes.
Mondays. Has she joined?
Not yet, I think. But I had sent reminders to everyone.
Yeah, so please.
Shall
let's
I
keep-
upload my slides? Like, shall I start sharing my slides?
Oh yes, you know they'll
that
be
I
just
can
doing. So
restart.
just check it. Just have a run that they are running.
Yeah.
So
Yeah.
Vidhi ko, Sudeep ji, by the time our guest and guest of honor are joining, let Dr. Vidhi check it out, and then for a few minutes we'll be we'll be sharing our screen, Dr. Vidhi. So check that it's running so that we don't lose time in between. Okay.
Yes.
All
I
right.
think Nuzhat ma'am has joined.
So is my slide visible?
Yes, Vidhi.
Okay.
Okay.
Good evening, Dr. Nuzhat.
So, shall we start?
I'm just putting the first slide.
Yeah.
Whenever you will tell me, I start.
No, first we will be doing our little bit of lamp lightning, Vidhi. So you will have to, stop share for a second.
Okay.
I mean, for a few minutes, and then we'll start sharing again. Okay. Okay. So I think Anjum, we can start.
Yes,
Yeah.
yes.
Yeah. Just tell Sudeep ji to start and
Yeah.
share the screen for
Stop sharing.
introduction. Okay.
Sudeep sir, can we start with
Yeah, it's live now. You can go ahead.
Is Dr. Manila here?
Not yet, ma'am.
Anjum, I think Dr. Manila is there, but she has joined the wrong link.
Okay.
So maybe Sudeep ji can do that and you can begin.
Yes.
And
Good evening and a very warm welcome to all our eminent faculties and delegates who have joined from all over the country. The Focus web series, webinar series that has been directed by Archana Baser ma'am, we usually focus on topics which are clinically relevant to the practicing obstetrician and gynecologist. So one such topic that we are taking today is on safety of cesarean section. We all know that it is a very most commonly performed surgery all over the world, and we always about it in terms of like a routine surgery. But we all know that no cesarean is routine. It comes with its own unique set of challenges. So today we are going to focus on how we are going to improve the safety and maternal outcomes with each cesarean section. So without wasting time, I would like to request Dr. Manila Kaushal Jain ma'am to introduce Program Director Archana Baser ma'am. Has she joined, ma'am?
I don't know, but you can take my CV and you can introduce. I
Yes.
think they can, yeah.
Yeah.
So
Sudeep sir, can I have Archana Baser ma'am's CV?
I think he is projected. So
I'm not able to see.
Until then, I will just talk a little bit, Anjum.
Sure, ma'am. And we are
yeah.
very thankful
Don't
to
think
you
Dr.
for
Arjun
guiding
Baser
us in this
is any
focus series always.
She's Vice President of OXI and Chair of MP ISAR. And I think soon she will be the President of OXI. She's extremely capable and she's done these wonderful FOXI focus webinars with the help of the West Zone team, which has really supported her throughout on diverse topics. And I really wish her all the best and I request everyone who is here to cast their valuable vote in her favor. All the best, Archana.
thank you. Thank you, Purnima, for the kind introduction. You have been such a great friend and great supporter throughout. So let me take over from here for your wishes. And what can I say? At the outset, let me welcome each and every one of the faculties on the dais who have joined us today in spite of their busy schedule. But the topic chosen is very, very important today is the cesarean section, which is every day performed. You are performing it every day, but there are challenges which we face, as Anjum has said. So, this focus series we started about 1.5 years ago with Dr. Purnima Satoskar giving us an opportunity to take one topic, focus topic, and do it. And then I'm being supported very well by team of West Zone fellows and representatives, especially Dr. Anjum, Dr. Rupali Dharwadkar, Dr. Manila Kaushal. They have been instrumental in connecting different zones of RCOG on this platform. So that's how, let me tell you, with this series alone, we could connect with almost 800 RCOG members from this platform, north, south, east, west, which has been a phenomenal, and that we got to know each other. And today, for this webinar, we have our chief guest, Dr. Mahesh Gupta, and we have our guest of honor, Dr. Nuzhat Aziz. I don't know whether Mahesh is joined, Dr. Mahesh, but Dr. Nuzhat is here. And we have very eminent speakers today, Dr. Vidhi Chaudhary, Dr. Mallikarjun, and we have Dr. Uma Devi as a chairperson. I have Siddesh Iyer as my co-moderator for the panel. And we have panelists from not only the north, south, east, west, but we have from we have one international member as well, though she's from the West Zone. So we have Dr. Srimati, Dr. Alia, Dr. Rashmi, Dr. Jayashri, Dr. Kavita, Dr. Arnav, Dr. Richa, and Dr. Arnav Basak, and Dhwani is our master of ceremony. So I welcome you all, and let me take this opportunity to introduce Dr. Nuzhat Aziz, if Dr. Mahesh is around. And Dr. Mahesh is there, Dr. Anju, or no, na? So let's just take Nuzhat is a great friend, and she has been, we keep meeting each other in different conferences. She's currently working as consultant, and after seeing a the first obstetric emergency department at Fernandez Hospital. She has led obstetric emergency department. I know she has lots of research papers to her credit, and she is a very good speaker, very good friend. And her current areas of interest are obstetric triage and streamlining obstetric emergency department. And she has a special interest in high risk pregnancy, maternal morbidity reduction, quality and risk management, and digital health and EMR. And I welcome Dr. Nuzhat to give your inputs, your advice, and your blessings to this webinar.
Thank you so much. Thank you for making me a part of it. And I thought, just it would also give me an opportunity to be among all of you and also learn, explore, new ideas. And I thought it would be really nice to join you. So a big privilege and an honor to be invited. So, and I am looking forward to it. Thank you so much, Anju.
Thank you, Nuzhat. Thank you so much for joining in and for your blessings to this webinar. And now I think we can go ahead with our scientific program, Dr. Anjum. Or when Dr. Mahesh Gupta joins, we'll introduce him. He's a person who is known as the person who's handling the PPH. He has done. Can I have the CV of Mahesh Gupta so at least people know that? Sudeep ji, can we have the CV? Yeah, so Dr. Mahesh Gupta is a person who has received Foxy Star and Foxy Legendary Award, and she's the one who is known for his work on the PPH. He has patented his suture material, and he has developed tertiary referral center for placenta accreta syndrome, and he does conclaves, focused topic, a great friend, a great teacher, and great academician. So I think when he comes, we'll ask him to give his inputs and blessings. So over to you, Anjum, to move ahead with the academic program and invite Vidhi for her talk.
So, ma'am, Dr. Basir, ma'am, I'm there. I'm really sorry because of technical glitches, I was not there. I would like to take an opportunity to introduce again. Dr. Anju, would you allow me to do so?
Definitely.
Just very briefly, because I'm already being introduced. So just be brief.
I'm really sorry, ma'am, but I want to take this opportunity because you had been a dedicated person to Foxy and women's healthcare, and you've served to many, positions in Foxy, like vice president and chairperson of Foxy Imaging Science Committee, organizing secretary of AICOG, chairperson of MP ISAR, fellow representative of AICC RCOG West Zone, and held several important positions in ISAR, IAG, ICOG, AOFOC, and CEFOC. So ma'am, your leadership, vision, and unwavering commitment have earned you immense respect among us and across the country. So today, Dr. Archana Basir stands for Foxy presidential candidate for 2026. She represents experience, integrity, and academic excellence, and an inclusive leadership quality as well. So I sincerely request each one of you to extend your wholehearted support by casting your valuable vote for Dr. Archana Basir. Ma'am, I wanted to take this moment because this will be the only time when I can request everyone who is listening us on this platform that please vote. And for you, you are a visionary leadership. Your dedication will make Foxy stronger in future. So I welcome you, ma'am, again. We are honored to have you, and under your leadership we were doing so many webinars over last months, and we look forward to your inspiring thoughts. Thank you so much, and thank you for taking extra time.
Thank you, Manila, for your kind words. You've always been generous in introducing me. Thank you so much, and you have been a pillar of strength in these webinars and throughout my journey for the Foxy presidential election. Thank you so much for kind words and joining, and let's move on with the academic program now.
Thank you, Archana ma'am. Thank you, Manila ma'am. Thank you, Purnima ma'am, for your kind words. May I request our Master of Ceremony, Dr. Dhwani, to start with the scientific session. Dr. Dhwani is a gynecologist practicing in Mumbai. She has done her MS MRCOG and also a degree in law.
So
Oh.
thank you very much, Dr. Anju. So without wasting any time, I will start my topic given to me.
Ma'am, can I just introduce our
Can you
chairpersons
please
before you
unshare
begin?
so that I can?
Ma'am, can I just introduce our chairpersons before we start your talk?
Yeah, definitely.
Yeah, please, please.
So, good evening, everyone. Thank you, Dr. Anjum, for a gracious introduction. And it is my pleasure to welcome you all to the scientific session of today's webinar. And this evening, we are privileged to have exceptional faculty of distinguished academicians and obstetricians who will share their expertise on optimizing outcomes and preventing complications during cesarean section. I would like to first introduce our esteemed chairpersons. Our first chairperson is Dr. Anju Hazari. Ma'am is an accomplished obstetrician and a gynecologist. She's also had her fellowship with Bernhard Baron Fellowship, London, and she's also done her gynec onco from Tata Memorial, and we don't need to introduce her anymore because she's well known. And but I think ma'am is busy with her with an emergency, so she'll join us in a bit. And our next chairperson is Dr. Uma Devi Karunakuran. Again, ma'am does not need an introduction. She's a expert senior obstetrician and a gynecologist, a fertility specialist with over 25 plus years of experience. And she holds several prestigious academic and leadership positions in India and UK. And she continues to make a significant contribution to women's health and medical education. So a very welcome to you, ma'am. And ma'am, if you could please introduce Dr. Vidhi, and she may then be the first speaker.
Okay. So good evening, everyone, and thank all of you for this excellent opportunity to have academic interaction with all the learned people from the northern zone of the RCOG. So I have great pleasure in introducing and welcoming Dr. Vidhi Chowdhury, and she's a professor of obstetric gynecology. She has DNB, MRCOG, and FRCOG, and the diploma in endoscopy. And she's professor, Department of OB-GYN at Lady Hardinge Medical College, New Delhi. She's a nationally recognized academician and gynec endoscopy expert, MRCOG examiner with extensive postgraduate teaching experience and faculty at various national and international conferences. And her special interests are minimally invasive gynec surgery, high-risk obstetrics, and medical education. So I welcome Dr. Vidhi Chowdhury to give her first talk.
Thank you, ma'am. Thank you for the kind introduction. So I'll begin my first talk. I hope my slides are visible.
Yes.
Yes.
Should go to slideshow.
So I'll be talking about a very pertinent topic, which is pre-operative planning and intraoperative best practices in cesareans in obstetrics. By and large, there are guidelines which have been very recent, which have been made for cesarean sections, but we can follow it for all the operations which we do during in an obstetric patient. So what are these? So basically, the Enhanced Recovery After Surgery Society recommended certain guidelines to be followed for maximizing the patient outcomes in cesarean sections. So these recommendations are very well meant, and they have been formulated what to follow during antenatal period, preoperative, and the intraoperative period. And these interventions, when followed, can make the cesarean delivery safer and will optimize the patient as well as the health facility outcomes. So going one by one, so I'll be covering this. So there are 6 key interventions for enhanced recovery after cesarean sections, and the key to note is if you want to have a positive cesarean delivery, positive outcomes after the cesarean sections, the learning begins from the antenatal period. So it is very important that there is clinical readiness and education about the women, especially the women who are having a previous cesarean scar, or there are women which may be at risk of having a cesarean section. For example, if you encounter a PAS syndrome at 20 weeks of gestation, or you are dealing with a woman with a previous to cesarean section, which you know will definitely go on have to have elective cesarean sections. So though the evidence level is low, but it has been strongly recommended that comprehensive education of the patients as well as the staff involved in giving care to these women should be given. And the patient education goes a very long way, in optimizing the outcomes. The second important thing is the multidisciplinary comorbidity optimization. So there has been a lot of papers and very well-meaning research articles which has shown that the comorbidity optimization, that is taking care of the anemia, obesity, hypertension, and diabetes, controlling them and formulating a proper structured physician as well as involvement of a gynecologist in optimizing its outcomes actually helps a long way in optimizing the cesarean outcomes. So it is very important, and this recommendation is also very strong and the evidence is moderate. And here they say if you control the anemia, if you take care of the hypertension, it will optimize the outcomes. The third thing is the immediately pre-surgical preparations. So I'll be talking about the nutritional intake and non-particulate carbohydrate loading in detail. So it has been said that there has been a lot of mixed data on the number of hours of fasting prior to cesarean section. So going on to this, I would like to tell you that there is insufficient evidence of the relationship between the fasting time for clear fluids and solid foods and the risk of pulmonary aspiration. Though they say preoperative fasting should be minimized, but the quality of evidence is still low and the strength of recommendation is weak. So by and large, worldwide it is followed that 6 hours of fasting if the patient has taken a clear liquid, and 8 hours if it is a solid food if the patient has taken. This much of fasting is required. But again, the strength of recommendation is weak. But as the data is not available, so recommending a light meal 6 hours before surgery or 8 hours before surgery is plausible. A good thing which has come is the non-particulate carbohydrate drink. This can be administered 2 hours before a scheduled cesarean delivery, and it has not shown any complications. And they say that intervention, they seem to be safe, and quality of evidence is moderate and strength of recommendation is strong. So a non-particulate carbohydrate drink is a non-particulate one. It is not a solid food. It is not a light food. It is a light glucose drink, which does not have any particulate matter. So this has been a new recommendation. If the patient 2 hours before you can give, this actually prevents any kind of hypoglycemia during the surgery. Now, another important intervention has been the 2% chlorhexidine glyconate. So the evidence says application of a cloth, a gauze dipped in 2% of CHG evening before the delivery, or taking bath either evening before the cesarean section is planned or during the morning of the cesarean section. So both are equally good, and it has a moderate evidence, and this can be applied for the antisepsis. So the 6 key interventions I would like to reiterate, which enhances the outcomes after the cesarean, that is antenatal and preoperative care, which includes comprehensive education and for the patients and the staff, optimization of anemia, obesity, hypertension, diabetes, even autoimmune disorders. Basically, any medical disorders or obstetrical disorders should be optimized. The strategic nutritional intake in terms of non-particulate carbohydrate drink is feasible 2 hours prior to the surgery, and fasting of 6 or 8 hours depending upon the meal taken, whether it's light or a solid food, and targeted skin antisepsis, which is application of a 2% CHG cloth or bathing with the solution containing 2% CHG either prior to the cesarean, evening before the cesarean section or on the day of cesarean section. So these 6 steps have shown a very good outcomes if the patient undergoes a cesarean section. The second I would like to talk about the enhanced recovery after cesarean delivery protocols, which are intraoperative. So there are certain intraoperative protocols which are to be followed to optimize the outcomes. And these are very recent update. They have been published in the American Journal of Obs and Gynae, and they have taken the evidence from all the leading societies, the NICE guidelines, the Canadian guidelines, that they collated all these data into one. So let us see what these people say, what these guidelines say. So there are actually, as per this, there are 10 pillars of the enhanced recovery after the cesarean section. And these 10 pillars, if they are followed, 99.9% the patient is going to have a very positive experience after a cesarean. Even the healthcare staff also is able to face the situation, and they will have very minimal complications with this protocol. So first is the clinical and procedural standards. So what do we have is the prophylactic antibiotics 1 hour before the incision. So that goes a long way in preventing the sepsis in a patient. So this combines the prophylactic antibiotics and the abdominal and vaginal preparation to minimize the post-surgical complications. So in infection preventions, both the things are equally important. That is administrating antibiotic and the abdominal preparation before cesarean sections. The second is the uterotonics and the thermal optimizations. So now to maintain the normothermia throughout the procedure goes a long way in preventing the complication, and the optimal uterotonics is a must to stabilize the patient during the procedures. So we give oxytocin as soon as as soon as the baby is delivered, within a minute, 10 international units IV during the cesarean section. So this must be given unless contraindicated. And as far as prophylactic antibiotic, the evidence is also quite moderate to high, and recommendations is a strong recommendation. So is the abdominal and vaginal preparation. Evidence is moderate and strength of recommendation is strong. Then the hemodynamic and the fluid stability. So patients should not be hypotensive during the procedure. So it is imperative to maintain the euvolemia throughout the surgery. Also, the pharmacological interventions which are recommended during the cesarean sections are that antiemetic protocol and the pain relief should be there. Like patient should not feel pain. Many times, the spinal analgesia may not be sufficient. So patient may feel pain. So both intraoperatively and postoperatively manage with the analgesics, and it goes a long way in having a optimized outcomes. Then the patient support. One thing I forgot, the patient support during the start of the surgery by the healthcare provider goes a long way in having the best possible outcomes. And the final is the early skin to skin care. So it optimizes the neonatal outcome. So immediately bonding to improve the maternal fetal outcomes directly in the operative room. So as soon as the baby is born, after making the baby dry, it is better to latch to start the breastfeeding, or at least provide skin to skin care. It helps the bonding, and it helps in managing the neonatal outcomes. So this is in detail about the enhanced recovery guidelines to optimize the cesarean delivery outcomes. So it's the same which I have told you, which is the support of the persons in the OR, prophylactic antibiotics, surgical site maintenance, physiological maintenance. They have given a very strong guidelines regarding the maintenance of the euvolemia, prevention of the hypothermia, and prevention of the spinal hypotension. For pharmacological optimization, they have emphasized on the optimal use of utrotonics, antiemetic prophylaxis, and the multimodal analgesia. So patients should not feel any kind of pain during and 24 hours post cesarean also. And the in neonatal outcomes, the skin to skin care goes a very long way in the neonatal adaptation to the environment. So, these are the same intraoperative guidelines. I would recommend all the postgraduates and even the residents who are listening to this lecture to go through these guidelines. They are very concise and they are very easy to follow, and they can be very easily implemented. All the pillars can be very implemented in the your obstetric unit, both the antenatal and preoperative and the intraoperative recommendations. So why they are useful? Because it leads to accelerated clinical delivery, shorter hospital stays, better healing of the wound, faster ambulation. It increases the maternal and neonatal well-being. And also in the intraoperative period, all these analgesia procedures are followed. So they also lead in the reduction of the analgesia requirement later on. It improves the breastfeeding success, and it does not burden the healthcare system and efficiency. So with this, I end my lecture and room is open for discussion. I was asked to cover intraoperative and the preoperative aspects of the safer cesarean delivery, so I've covered that.
Can we take, can I comment and then go on to the next speaker?
Yes, ma'am.
So I just tried to make the lecture visually appealing, and I incorporated everything in an infographics. So I could have gone through all those guidelines but I think giving it a picture and breaking down into simpler, easier, comprehensible facts are better for the audience to grasp.
Yes, that was the best part, Dr. Vidhi.
Yeah. So
well, know everything in one slide.
Yeah, so the 10 pillars, intraoperative, 6 pillars, antenatal, and that is all. We usually do in our practice, but we tend to forget.
Excellent. And all the information you have covered. I can add just a few points like practical, no? That new guideline where we need to fast only 6 hours for solid food and 2 hours for the liquid food. I think the people might ask what to give. I think we prefer to give them apple juice, that is non-pulpy juices, and milk-free coffee or tea. So that can be entertained, except for those high-risk patients where I think we will not like to give anything for those patients. So otherwise, for the routine cesarean section and for people who come for emergency or elective, I think you start right from 10 weeks onwards, optimize the maternal health. And then so I think the next speaker, Dr. Kirti, will be talking about how to optimize maternal health.
Yeah.
Maybe that preventing hypotension is another thing. We always give IV fluids to prevent that. But now the guidelines say we have to give them ephedrine or phenylephrine in addition to IV fluids so that hypotension will be prevented. And also warmed fluids, IV fluids, always keep up. Not to go for hypothermia at all. It will go good for mother and baby bonding, and also for to prevent complications. Wonderful lecture. It was very good. And
thank you, ma'am.
Very much.
Thank you so much, ma'am.
Uma ma'am, can we just request our Chief Guest Mahesh Gupta sir, I think he has joined, to address our webinar for his kind words. Can we have Gupta sir to say a few words?
Good evening all. It's a pleasure to be in the such kind of the webinar when the practical topic is to be discussed.
Hi Mahesh, let me welcome you.
Yeah. Dr. Archana.
Welcome Dr. Mahesh on this platform of focus series by RCOG West Zone, where we on the same platform we bring North, South, East, West. I have already introduced you. You are known as the PPH man of India, I should say, with your innovations and the way you work, and your conclaves are very famous, and I have attended. I think you have so many research papers and patents. So over to you, Mahesh, for your inputs and your words of wisdom to us.
Thank you, Dr. Archana. And at the outset, let me wish you all the best for your this Foxy endeavor, that is Foxy incoming election for president of Foxy. So all the best, very best for you.
Thank you.
Yeah, and I'm always eager and always interested to learn the practical topics in obstetrics and gynecology, and in particularly this cesarean section is of my choice that I always want to learn and to always collaborate with such kind of the webinars and the talk on a practical subject. And thank you for admiring my PPH conclave and my patrons. And here I'll be very happy to listen all this panelist and moderator to speak about the cesarean section. And again, I wish all the best for your this webinar. Thank you so much.
Thank you, Mahesh, for joining in, Dr. and giving your words of wisdom. And please stay with us. Our team has really prepared
Sure.
good panel, and we have Dr. Mallikarjun talking as well. So please stay. And over to you, Dr. Anjum, for taking it further.
Uma ma'am, can we introduce our second speaker, Mallikarjun Kirti sir?
Yes. So Dr. Mallikarjun Kirti, I have great pleasure in introducing him. He's from Bangalore, and he has been very active in all the RCOG academic sessions, and he has his own hospital. Can I have his CV? In a place called Chitradurga. His CV, please. Okay, I know him through the South Zone RCOG, BRCOG, Bangalore Society of Obstetrics and Gynecology. And he's both an MD and also MRCOG and FRCOG. And he has been an active member and contributing to various academic sessions, and a very good clinician as well. And then in addition to being an academician, he was a senior obstetrician and fertility specialist with 25 years of clinical experience in reproductive medicine, infertility, and advanced gynec endoscopic surgery. Can I have the CV? The previous slide.
Sudeep sir, can we have Mallikarjun sir's CV?
There are some more credits which I have missed out, I wish to say. Okay, anyhow, he has many papers to the credit. He worked in the UK, and he has held consultant positions in the UK, and has got his training, special training, and has come back to India to do good to the women of a country. And now he's established in Karnataka, and he will be giving his practical experience, and it's also about the Iraq guidelines, how to optimize the maternal outcome, how to make the mother safe during her journey of childbirth. Okay. So he has always been a leader, mentor, and he has got his own hospital, Kirti Hospital, and is consultant at Scotland. Thank you, Dr. Kirti. Welcome you and request you to deliver your lecture on enhanced recovery and optimizing the maternal outcomes. So these are some
Thank
of
you, Dr.
the elements.
Thank you, Dr. Madhav, for the introduction. I'm just trying to share the slides, and it's not allowing me to do that. Okay, so for some reason. Anjum, can you help me with that? I think I have some problem with the sharing.
I think there are some optimized elements which has to be taken care of, like an obese mother, a mother who is anemic, hypertensive, and Dr. Kirti will be covering all those aspects in his lecture.
There is a share icon. You can use that, sir. There is a share icon.
Yeah,
First keep your
and
slide open
allow
first.
to share the screen. Yeah. I'm clicking on, somebody is sharing there. I think someone has to stop sharing. Then only I can share, I think. Vidhi Chaudhary, could you please stop sharing yours?
No, mine, I've already stopped sharing.
Okay, but for some reason
Have
it
you kept
shows.
your slide open?
Yeah, my slides are open.
Just to press the green button share. There you can see
Yeah.
your PPT.
No, that's not showing. Okay, so
Application windows, there you can see your PPT. And then you can share the press button again. You select that and then press the share button again.
Anju, can you do that for me? I've sent your WhatsApp my slides just in case.
Working on it. Waiting on the WhatsApp. I haven't received it yet, sir. Yes, sir, got it. Yes.
Yeah.
Just a second. Able to see it. Sudeep, sir, can I put it in the group so you can share it?
Yeah.
I'm just sharing it there. Shared.
What's happening, Anjum? Sir has not been able to share his screen.
I'm not able to share my slides, madam. Sorry for this. Okay, so.
It's okay.
I think it's started sharing now.
Yeah.
Yeah.
Can we go for the slideshow? Yeah. So I think Vidhi Chaudhary covered most of it. So I'll just.
It covered antenatal and intraoperative part. So post-operative is still left.
Because I thought I'm covering the. Anyway, let me begin with ERAS for cesarean delivery. I mean, ERAS started with colorectal surgeons fast track surgery. He's Kellight's colorectal, and he started in 1990s. And slowly the guidelines have been adopted to most of the surgical specialties. And society was formed in 2010, and the cesarean specific guidelines, there are 3 guidelines published. These guidelines they have done based after the cohort studies and multidisciplinary studies and meta-analysis, and they're quite helpful, and I recommend everyone should go through those guidelines and please implement this practice, try to adapt in your institutions and in your day-to-day practice. The success depends on the bundle as a whole, not as a single element. So the core principle is to reduce the physiological stress of surgery, and then support the patient in recovering from what stress remains. There are 3 domains already Dr. Vidhi Chaudhary has discussed: the pre-admission and pre-operative preparations, intraoperative anesthetic and surgical care. and then the post-operative recovery. Here, RAC, early recovery after a cesarean section, includes not just the mother, the baby also. So the post-operative recovery, feeding and mobilization are very important. Then coming to the why cesarean delivery needs its own pathway. Yeah, as I said, there are two patients, two
Slide is
persons
not
involved. I can't move the slides. Someone has to second slide. Move the slide.
the second slide. Yeah, this.
Okay. Can everybody
Yeah, we can see that.
see the slides? Yeah. Okay, that's the first slide. Can we go to the next slide, please? Yeah, thank you very much. Why cesarean delivery needs its own pathway? So it's two persons involved, both mother and baby. So neonatal safety is important. The early discharge doesn't mean early recovery. So let's not concentrate only on the early discharge. So both mother and baby bondage needs to be established. And in cesarean, we are mostly dealing with a healthy young woman, and the baseline function is high. So the pathway targets rapid return to the independent self-care and infant care. Caregiving from hour one, because the mother has to feed, lift the baby, and care for a newborn while recovering. The surgery can be elective or intrapartum emergency cesarean sections. So the bundle needs to cover both aspects. The most common major surgery is the cesarean throughout the world. So the target is for the early recovery. The distinct risk profile include hypercoagulability, hemorrhage risk, and lactation. So what the evidence show is shorter stay. If you follow the Iraq guidelines, in general, the studies say that we can reduce the stay by 1 or 2 days. Less opioid use, faster function, earlier ambulance, earlier oral intake, and earlier catheter removal. Better experience. The mothers have expressed, as per the feedback and the studies, satisfaction with quick recovery. Of course, we need to consider special conditions like diabetes, hypertension, and other comorbidities like high BMI and all. The ERA Society cesarean guidelines, as already discussed by Dr. Vidhi Chaudhary, includes 3 parts: antenatal and preoperative care, intraoperative care, and postoperative care. Since already it's most of it discussed, I just want to highlight few things on the intraoperative care. Anesthetic technique, prevention of a spinal hypertension, as Dr. Umadi was mentioning, and nausea and vomiting prophylaxis, normothermia, uterotonics, and surgical techniques, and skin-to-skin contact intraoperatively. Postoperative multimodal opioid sparing analgesia. So most of the time we can manage the pain relief with NSAIDs and paracetamol. Early feeding, early mobilization, and early catheter removal, and thromboprophylaxis and lactation support, and a clear discharge planning. Next slide, please. The pathway at glance includes before, during, and after. So as it's already covered, I don't want to waste time and move on to the next slide. So I was not aware Vidhi Chaudhary was covering antenatal and preoperative care. So I'll just briefly go through it. So in India, I think we need to correct the anemia before. It's one of the commonest thing. Structured counseling of the patient so that the patient aware what her role is. and optimize the comorbidities like glycemic control, hypertension, smoking cessation, and nutritional status. Confirm the surgical date and pre-admission and anesthetic review is very important. Patient knows what to expect. Prophylactic antibiotics within 60 minutes of skin incision and weight-adjusted dosing. Coming to the preparation of the skin, chlorhexidine alcohol skin preparation, and consider vaginal preparation in ruptured membranes or any as the evidence suggests, preparing the vagina with a betadine or a chlorhexidine reduces the endometritis rate. Of course, we should use the standard protocols, the FOXI or the RCOG guidelines for VTA prophylaxis. Again, these things are already covered by Vidhi Chaudhary, so a lot of overlapping happening here. Apologize because I didn't know that these things are covered already. Intraoperative, I would like to add few things. Anesthetic elements, by default, we should consider neuraxial anesthesia, epidural and spinal are combined. Reserve general anesthesia for benign indications. Long-acting opioid provides the analgesic foundation. Prevent spinal hypertension with the prophylactic vasopressors. Multimedial model antiemetic prophylaxis, combine agents from different classes. Active warming and warmed fluids is very important to maintain the normothermia. Prophylactic uterotonic delivery and consider tranexamic acid wherever if emerge is anticipated. Surgical technique, incision and entry. So transfer skin incision, blunt entry rather than cutting, and delayed cord clamping, uterine closures, and I think I still see a lot of people using cat cut in India. I think people should move to Vicryl because cat cut can cause a lot of inflammation and long-term pain. Layers and drains. So closing subcutaneous tissue only if the depth is warranted. Otherwise, avoid routine, leaving the drains unnecessarily. Immediate skin-to-skin contact helps the bondage, and keeping the both mother and baby together also should be considered. Post-operative care and recovery. So every hospital should have a protocol so that the nurses are aware what to give, because the most neglected wards in maternity are the post-operative wards. So once the delivery is done, everybody is, the complaint is more, they're neglected more. So please let your staff be aware of what exactly the pain relief, how frequently, how they top up. Regional blocks with neuro, if it is epidural is there, you can consider them for top up, but encourage early oral intake. So the guidelines recommends within 2 hours, within the first hour actually. So mobilize early with first assistant walk on the day of surgery itself, and remove the catheter within 6 to 12 hours once the block is receded, and continue thromboprophylaxis based on the documentation. So proactive lactation. Okay, so all these guidelines, once you implement, you should audit, and the commonest pitfalls is just cherry picking and omitting the unplanned cesarean pathways, and just early discharge and recovery should not be the main aim. Okay. So
Water.
So take-up messages are ERAS for cesarean delivery is a bundle. Its whole pathway drives the benefit, not any single element. It's the antenatal preparation, intraoperative anesthetic and surgical care. It's a teamwork, including the obstetrician, anesthetist, and nurses, midwifery, pharmacist, and whole team. So the two patient means every element is judged for maternal benefit and fetal safety together. Auditing and multidisciplinary ownership determines whether the pathway survives past year one. Thank you very much. Can we have more discussion, please? Okay.
Thank you, Dr. Kirti, for that comprehensive discussion of pre, peri, intra, and post-operative pathways in ERAS. So you have discussed almost everything. The post-operative pathway, I think some practical points like how to encourage early feeding. They say even though the evidence level is low and weak recommendation, but many studies show that asking the patient to take chewing gum within 2 hours of the surgery helps the mobility of the bowel. And so that has been found to be useful. Many of us are already following early feeding. So it may not be applicable to those people, but where some follow late feeding, probably you have handled the bowel or something and you don't want to take oral fluids, liquids quite early, then you can advise this chewing gum. It is found to be very beneficial in many of these studies. And also to prevent post-operative nausea and vomiting, you start right from intraoperative, that is prevent hypotension, and give both antacids and H2 receptor blockers. And that has been found to be very helpful in the prevention of nausea and vomiting. And if the mother does not have this, she is encouraged to take orally very early. Then the removal of the urinary catheter as early. We can even do the cesarean section without catheterization by asking the patient to empty the bladder to avoid the infection. But if you have put in a catheter only for the section, you can remove the catheter, but you will have sometimes the patient may not be able to void. So it would be a good policy to keep for 6 hours and then remove the catheter post-operatively. Then post-operative avoiding opioids. This goes a long way in preventing dependence on opioids. And they say that always a combination of drugs. We give paracetamol, and also here, if the mother is not preeclamptic, we can give her ibuprofen. A combination analgesia always works better and the mother is pain-free. And in the post-operative period and also intraoperative, pneumatic cuff compression in every cesarean section would help a long way to prevent thromboembolism. Then in the post-operative period also, the both mother and infant bonding to be held, breastfeeding to be encouraged, and to start a discharge plan very early and give a good discharge plan to the patient and the people at home who are ready to help her out. And if everything is assured, the patients are discharged even after 24 hours, and which may be a little early to adopt in our setup because many of them may not be able to go back and look after themselves, and they are not so educated and they'll be apprehensive about discharging them early. So we may not be able to adapt all these IRAC pathways. Maybe we have to modify. And even though they say that it is good to prepare with the chlorhexidine scrub, I think many of us, including all of you, may be using povidone iodine, and I think we can still continue with the povidone iodine and follow the skin preparation. And also the vaginal preparation is very much needed before surgery. Vaginal cleansing with the povidone iodine solution. And early mobilization, of course, is very, very important, and encouraging them to walk around before they are discharged. So the other thing about the optimizing maternal outcome in the antenatal period would be, there are some modifiable risk factors. Some risk factors which we cannot modify, like the age and other things we cannot modify. But at least if the mother comes and we find she is having a high BMI of more than 40, then definitely this lady is going to have a lot of problem. So taking care of her and how to prepare ourselves to do the cesarean section, and how to care pre-operative, intra and post-operative for these obese women, and optimizing that would be very helpful. And if she's a gestational diabetes or a pre-diabetes, optimizing them with insulin and follow all the guidelines for that. And in that way, we can optimize hypertension, diabetes, anemia, prevent smoking, and also manage fetal growth restriction and large for gestational baby, and something which we can modify. So modifiable risk factors can be optimized to have a better maternal outcome. I think otherwise everybody has, both of them have covered very well, and it is gonna double dose has helped us also to understand. Repetition is
Yeah,
also good.
just can I say a few words, madam, if you don't mind? Okay, so I've seen a lot cesarean sections from small places in India to all the corporate level in India, including major cities, and also I worked in UK and all. Still, it's still we are lagging behind in early recovery in places. If you move a little bit towards a small taluka place or district place away from the major metropolitan cities, still I see a lot of obstetricians are still practicing 48 hours of IV fluids and slow recovery. Not many are using thromboprophylaxis. I think lots needs to be done to improve this. The all these things are concentrated in the major cities. So I mean, in the lower setups, especially taluka levels and the small places, and also in the government setup. So I think if we are really aiming to improve the women's health in India, we should concentrate delivering the services in those areas, I think. Yeah.
Thank
Thank you
you.
very much.
Thank you, ma'am,
Thank you.
for the wonderful talks. Dr. Dhwani,
Yeah.
can we start with the panel discussion?
Yes. Thank you, ma'am, for your thoughtful deliberation and giving us your valuable insights on the very important topics that we have just covered. And now we should move on to what promises to be one of the most engaging segments of today's webinar, the panel discussion about complications we never want during cesarean section. I would like to introduce our moderators. Our first moderator is Dr. Arshana Baser. Obviously, ma'am has been introduced earlier
My
also.
introduction has been done, so we can
Yes,
just
ma'am.
pass it and let's introduce Siddesh and then we can start.
Yes, ma'am. And it is now my pleasure to introduce Dr. Siddesh Iyer. Sir is a director at Saukhamya Hospital, Mumbai. He's an accomplished laparoscopic surgeon. He's also an MRCOG Part 3 examiner and was a former member of AICC RCOG International Representative Committee West Zone. Sir's expert.
I think we can start the panel. I think.
Sure, sir. So I would also like to say a very warm welcome, and I would like to introduce our distinguished panelists. So it is my honor to introduce Dr. Srimati Raman. Ma'am is a consultant obstetrician and a gynecologist at Rangadore Memorial Hospital at Bangalore. And she's also a joint secretary at BSOG with special expertise in maternal medicine and clinical governance. Can I have the next CV? Next is Dr. Alia Zaidi. Dr. Alia is currently practicing in Doha, Qatar, with special interests in minimally invasive surgery and reproductive medicine, and is a passionate advocate of patient counseling and women's health education. Can I have next slide, please? Dr. Rashmi Patil, it's my honor to introduce ma'am. She's one of the dynamic parts of MRCOG or rather RCOG, AICC RCOG. And ma'am is a consultant at Apollo Hospital, and she's founder and CEO of Raise Academy. She's accomplished academician with multiple national awards and leadership positions. Ma'am, I think, is caught up in an emergency surgery, so she isn't available. Can we move on to next? Dr. Jayashree Sundar, she's a senior obstetrician and a gynecologist with special interests in preventive gynecology, high-risk obstetrics, and postgraduate postgraduate teaching. Ma'am also has been a part of many RCOG courses and ICMR studies. Can I move on to next? Next panelist is Dr. Kavita Kapadia. We are delighted to have her with us here. Her areas of ma'am has been a consultant OBGYN at Ramaben Hospital, Navsari, and she's also practicing at Namaha Healthcare, Mumbai. Ma'am's areas of interest include fetal medicine, high-risk obstetrics, and her major achievements include advanced ultrasound, Doppler and fetal 2D echo, and she also has an award-winning paper on the uterine artery embolization in case of placenta accreta. Can I have next? Dr. Arnav Rishikesh Pai is also an obstetrician and a gynecologist. He's also an infertility and IVF specialist and is an expert in robotic and laparoscopic gynecological surgeries. He's currently the chief consultant at Budget Friendly Pearl Center in Mumbai and a founder and CEO of PRH Healthcare. Can I have the next panelist, please? Yes. Dr. Richa Upadhyay, she's a consultant obstetrician and a gynecologist with training, fellowship training in reproductive medicine and IVF from Kraft Hospital and Research Center, Kerala. Ma'am has had multiple publications and she has a very broad teaching experience, and she's had many previous positions held across our country. Can I have the next? Dr. Arna Basak, sir is a senior consultant in Apollo Multispeciality Hospitals in Kolkata, and sir is an expert in minimally invasive surgery, pelvic surgeries, robotic and high-risk obstetrics. Sir holds decades of clinical experience, and he's currently the president of Kolkata Menopause Society and treasurer at IAGE Bengal chapter. So has been mentor to many residents and surgical fellows, and I think he's had really amazing positions over the years. So we're truly honored to have such an accomplished panel of experts with us this evening. Can I request our moderators to please take over and commence the discussion?
A very good evening to all of you. I think I'm really excited to moderate this panel where we have panelists from all over the country, north, south, east, west. And then, all of us have different kinds of challenges in our practice. Can I be allowed to share my screen? And yeah.
Ma'am,
So,
not only East, West, and even outside India, we also have somebody from Doha. So we have even an international panel on our board.
yes. So Alia had been with me, and I think the case which I am bringing, because we have two parts of the panel, just to inform the panelists. We have such a brilliant panelist, all MRCOGs and from Mumbai, Kerala, Kolkata, and Gujarat, everywhere. So Alia had been with me, and I think the case which I bring, maybe Alia was part of the management as well. So we have done the two parts of this panel. One, I'm just going to project a case, and then Siddesh is going to take you through, like the stepwise how really we should prevent, recognize, and manage the complication. So let me begin with the case. And these are the panelists which are already being introduced. Siddesh is my co-moderator, and we have interacted on different platforms, and we have been in different forums together. So why we are talking about C-section, let's just for 1 second think about it, because it's a commonplace occurrence and it has been practiced for hundreds of years and one of the world's most commonly performed surgery, but still the challenges are faced by all of us when we talk about cesarean section. And in the cesarean section, if you see, the problems comes in many shapes and many sizes. There can be expected difficulties. You are well prepared, you know. There are sometimes unexpected complications. You have to make choices in operation theater. And there's a new thing which is coming up, is a social obstetrics, which is a new challenge. And sometime things just go wrong. Whatever you do, howsoever you are prepared, but that's not your day. So that's what. So these are the problems of expected difficulties, where you have obese women, you have comorbidities, you have previous scars, your malpresentation, multiple gestation, placenta previa, IVF conception, preterm, and pregnancy with fibroids. And these are all going to increase, as we know that, the women are conceiving at the advancing age, ARTs being more and more, pregnancies are with ART, and fibroids, endometriosis, all are increasing. What about if I say that all problems in one? So I'm just presenting a case where all problems happened in one, and then I'm going to take the opinion or inputs from all of you. So this is a case where she's Mrs. MC, 35 years, 125 kg. Her height is 5 feet. She had no live issues, one abortion, one ectopic, for which she has laparotomy, not the laparoscopy, and that was operated. She had myomectomy for several fibroids. This is ICSI OD conception, twin pregnancy, heavy bleeding in first trimester, severe hypertension on 2 antihypertensive medicine, severe vertigo. She is now obese, previous 2 scars, hypertensive, twin pregnancy, 35 weeks for C-section delivery. So I know these are the problems which are anticipated, anesthetic, obstetric problems, there can be pediatric problems, and there can be the problems in the recovery. So my question to you, Dr. Srimati, what will be your pre-operative preparation for this patient? Because these kind of cases are going to become a common presentation to the modern obstetricians. So let's talk about stepwise, what pre-operative preparation will you do in this case?
Yeah, thank you, ma'am. As you rightly said, I think all of these problems are coming up more commonly, and our average population, the BMI is raised. So here we are thinking in terms of raised BMI, hypertension, IVF. I mean, IVF is okay anyway, twins, and of course, previous 2 scars. So these are the problems which we have. So preoperatively, I think one is obviously having a pre-anesthetic clinic. I think that is very, very review with an anesthetist so that we can plan it. 2 is, I think, a discussion with the nursing and all the staff, because handling, her weight is 190. I mean, I hope that is the current weight and not the, sort of booking weight. So how much can the OT table handle? How are we going to do the moving and handling? So those aspects have to be looked at. And also optimization of anemia, looking at the placental site, because, with her previous myomectomy, we do not know where the placenta is there any chance of placental adherence, and what kind of a scars, is there suprapubic scars or what kind of a scars, and also the access to the abdomen, how big is a pan is, so that I can plan the scar, and also whether there are any current fibroids, and also to complicate it, there's going to be twins. So I will have to plan the delivery, especially for the second twin, how I have to sort of stabilize and deliver, and having an NICU preparedness and being prepared for BPH. So making sure a hemoglobin is optimized, and also having blood and blood products cross-match. And also I would probably have at least 2 senior obstetricians and maybe a surgeon on standby, because I do not know whether there is going to be any bowel or any adhesions which I'm going to sort of encounter.
Thank you. Thank you, Dr. Srimati. I think you have very well covered that what pre-operative preparations will be there. Let me ask Dr. Arnav, he's a young gynecologist. Do you think that you will take a special consent for this patient? Because you know she's a very, very high risk and anything can go wrong, though you are well prepared. So what kind of consent you will take, and how much you will let the relatives know that what all can go wrong in operation theater because of her weight, because of her twins, and because of her previous surgery. So over to you, Arnav, for pre-operative consent, what kind of consent it should be?
Yes, ma'am. Thank you so much for having me, first of all, in this panel. It's truly an honor. So, when it comes to the MRCOG and the RCOG, the consents are extremely important. It's very important to make sure the name and the details of the patient are written comprehensively in each and every consent. One thing is that never hold back on the consent. You have to be honest and you have to say every complication as it is to the patient as well as the relative. As we know, there are many high risk factors in this case. We must cover each and every one of them. Pertaining to surgery, of course, all the intraoperative complications that can occur, which would be the preeclampsia related complications, like liver failure, renal failure, as well as convulsions, even intraoperative problems such as a bladder injury, bowel injury, previous surgeries and adhesions, a difficult delivery, need for blood transfusion, anesthesia related problems. All of these things have to be touched upon. We must also include the very, very severe possibility of needing an obstetric hysterectomy. So we must not hold back on any of these things. Even a thromboprophylaxis as well as clot-related complications, all of these must be mentioned. The patient signature must be taken, and it should also be made sure. A part where people don't really follow up is that she must understand each and every complication. It should be explained to her. A high-risk consent is mandatory in this case.
Excellent, excellent. And I think Foxy also has some high risk consents, and consents are being done. So I think consent becomes a very, very important part of the as doctor has already said, pre-operative preparation, and the consent is very important. Now let me ask our international expert here, Dr. Alia Zaidi. She has, I think, probably been in this case, if I'm not mistaken. What will be the anticipated intraoperative challenges, Dr. Alia, which you would like, to put light on?
So, firstly, thanks a lot for giving me this opportunity. It's such a exceptional panel, and I really feel privileged to be a part of this. I don't think I was a part of this case particularly, but Archana ma'am has been dealing with such high-risk cases, and there have been many, many such cases with multiple anticipated complications that are there, especially because she has IVF unit, and with ART, the chances of having placenta previa, vasa previa is very high. In this particular case, we have a lot of things, as explained by Dr. Arnav and my Dr. Srimati, about the pre-operative consent taking, high-risk consent. It should be written and should be in the language of the patient, and she should understand. We need to anticipate, of course, there are previous surgeries done. So the presence of a senior experienced anesthetist intraoperatively is very, very important here. Two senior obstetricians and a very experienced assistant is very important, because we are anticipating a difficult entry in the abdomen. Preparedness of your senior team in the OT, because it's a heavy patient, the transfer of the patient to the bed. Then just going the NICU, senior neonatologists have to be involved here. And also not to forget that we need two separate neonatologists here and two separate team of NICU nurses here, because we are dealing with preterm twins. Of course, one thing I also want to mention that we didn't, although the data is different now according to the research, but we do still, as good practice, need to cover the mother with antenatal steroids, just to mention the preoperative part. Apart from this, when we go inside the surgery, important in anesthesia would be the choice of anesthesia. The PET bloods that we do before the surgery, because if the mother's platelets are low, then of course regional anesthesia will not be possible. And we know in PIH, with the obesity and the PIH, there will be airway difficulty and edema. So that's why it's very important to have a senior anesthetist on board, because it might just turn into a GA. And that is also important in pre-operative counseling as well, that this patient is not only anesthetic high risk, not surgical obstetric. So she's a high risk in every possible way. Now, going into the surgery, it's very important to have a tilt. I remember Basir ma'am would have a tilt for almost all the patients to prevent the cable compression. When we go towards the incision, of course, chlorhexidine antisepsis, everything has been explained by, and I'm making it quick so that we get more time to discuss. The pannus is very important, that we put the incision in a way that the pannus doesn't come. So, and when we enter, there is a lot of data now on the entry techniques. And if we go in a paramedian way, because with this two previous laparotomies, and plus we have a history of endometriosis. So a paramedian way of entry would prevent going directly into bladder. So that's one thing. The other thing is tissue handling. That is also extremely important here. And the third thing that I was, it's very important to dissect the bladder completely intraoperatively, because we don't know, we may have an extension. As already explained, it's a preterm twins. Sometimes also we need to give the incision slightly above, because the lower segment of the uterus will not be completely formed. In case of PPH, we may have to deal with sutures, or lower leading sutures or anything. So it's very important that the bladder is dissected very well, so that we get the access. Finally, coming towards the end of it, if I have to wrap it up quickly, it's also a good idea, or also recommended, or to use probably a negative pressure dressing in such patients to prevent post-operative infections. Antibiotic is already covered, and yeah, that's about it, if I have to say, intraoperatively.
Thank you. Thank you, Dr. Alia, for your inputs on this. Intraoperative is very, very important. One thing I just want to ask Dr. Richa, because sometimes, like she's an obese patient and we are dealing at 35 weeks, head may not be engaged, or what is the presentation. So do you use any instrument to deliver these babies? Because our hands may not catch hold of the presenting part. So what kind of intraoperative steps? I mean, few are being mentioned by Dr. Alia already. So just one or two points which might have been missed out, or a special thing which you do. What are the challenges you think you might be facing, and you would prepare yourself and keep the instruments ready to deliver the baby? Because the presentation, so does anybody keeps an ultrasound machine in the operation theater when you are dealing with such difficult cesarean sections in your labor OT?
Thank
Dr.
you so much,
Richa.
ma'am, for this opportunity, and hello to all the members of the respected panel. So yes, considering all these things, like what Dr. Alia has already mentioned, quite a lot of them. So keeping an ultrasound machine in the labor OT, labor room, whatever it is, it is definitely a good practice, and especially if we are considering twins with such high risk, with multiple adhesions that we are anticipating. Also, it will help in placental localization. Already we may have a scan, but still it will give us a better idea if we just can anticipate that there can be a surprise when we open the uterus that time. So intra-op localization of the placenta, that will be an advantage for us. And while doing the performing the surgery, we can anticipate if it is a free high floating head, there's a vertex, so we can aim for, because it is a preterm, so avoid venous delivery. So we can go for forceps delivery. That can be a good option. And along with that, because it is a cesarean, so there's no need for doing a version. So the second one can be delivered by breech, and whatever presentation, and that can be maneuvered accordingly. And one more thing I would like to add in the pre-op, intra-op preparedness that all doctors covered very wonderfully. We should always have a contingency plan in hand to be made by the team for the patient also. Just in case that some emergency comes up and patient lands up at dead of night. So how we are going to manage in that situation, that should be a part of the care plan whenever we are anticipating the delivery.
Thank you, Richa. I think very beautifully you have said that this was anticipated and well planned, but if what happens if you have to do it in emergency? So I think contingency plan should be there. I think now I have Dr. Kavita Kapadia here. So Dr. Kavita, what are the post-operative complications you are anticipating here? And then Dr. Richa, if you're here, to talk on thromboprophylaxis, and I'll hand over to Dr. Siddesh to take further. So Dr.
Good
Kapadia, are you
evening.
here?
Thank you so much for the opportunity. I think when I think of the post-operative complications, there are many that come to my mind. Of course, I would like to categorize them as post-anesthesia related. When you deal with a patient who is this obese, sometimes if the spinal has failed and you need to give general anesthesia, risk of aspiration, when these patients are obviously moved into the recovery room, there could be a high chance of hypoxia, so you need to watch on their vitals. Secondly, she's also hypertensive and diabetic, so maybe her blood pressure, if it's not under control, she stands at high risk of eclampsia, or even the uncontrolled hypertension could lead to some amount of cardiorespiratory overload, and she could go into pulmonary edema. So that is one thing you would like to watch out for. If her sugars are not in control at that point of time, a very high fluctuating blood sugar levels could also pose a problem. The immediate risk also would be in the form of postpartum hemorrhage. Sometimes everything seems okay in the OT, but the patient is shifted, probably the effect of all your prostaglandins and everything is over, and this patient could have a delayed bleeding after an hour and a half. So you have to be really very careful. Make sure that she doesn't, she doesn't bleed, and you have all the prophylaxis that you need around her. Also, you need to make sure that sometimes there's a lot of fluid shift, so they're not dehydrated, but they're also not overhydrated. Very important to keep a watch on the urine output as well in these patients. And auscultate, I think sometimes, for a brief period of time, you may miss the creps because of the sudden fluid that has shifted from the third space into the lungs and everything of that sort. Also, there could be a chance that the bowel or bladder are injured. So you really need to make sure that you're looking out for signs for distension. You're making sure that the urine output is adequate. The color of the urine is well maintained. You're also worried about sepsis. Of course, that comes in a little later and not immediate post-operative. So make sure that you've given her enough antibiotic prophylaxis, keeping her weight into consideration. And if required, not just a single dose, maybe you'll want to repeat the dose, and maybe you'll give the optimum dose for her. The other risk that she stands for, of course, which you have put below, is thromboembolism. I think that is one thing that we really need to be careful. Considering the weight, it may not be very easy to mobilize her. So you have to make sure that if you have a pneumatic compression device or at least elastocrite bandages, make sure that she's well mobilized. And if indicated, thromboprophylaxis, which in this case, considering obesity, diabetic, hypertensive, large body mass index, IVF pregnancy, a lot of these fall into a high risk category according to the RCOG, and you would actually consider even putting them on low molecular weight heparin 6 to 12 hours after surgery in case the bleeding is in control and you can administer that. So I think, these are all the post-operative complications that I can think of immediately.
I think very beautifully covered. So it is very important to avoid the dry kidney and the wet lungs.
Yeah.
That should be the dictum for managing women with hypertension, obesity. You don't want ventricular failure, and you don't want anuria. So it's very, very important. I think you have covered the thromboprophylaxis as well. So I'll just tell what we did. In this case, we prepared for the big team, big day, all, blood, sonography, OT assistants, OT technician. And we, as Dr. Alia has said, that we always keep the two pediatrician for twins. And this is, I don't know if somebody is practicing, I wanted to bring it, because if the abdominal wall is hanging with the previous scar, you can autoclave this, your elastoclass bandage. Otherwise, you have to put, two valsellums and valsellum, and then put that ribbon gauze and handle it. Sometimes it becomes very difficult. So this is something which we practice. And so now this was a difficult C-section, perfect suturing, everything. So I'm really thankful for all of you for your inputs. Now I'm handing it over to Dr. Siddesh to take it further and involve the panelists in discussion.
Ma'am, I want to add a few things on the case. One is it is best to not attempt these cases in smaller nursing homes, because as someone put it, that she might land up in the night. And even if she lands up in the night in a smaller nursing home and you're too tempted to operate, if you're not prepared, then it is better to shift the patient to an adequate center. Don't be tempted to go ahead and finish off the surgery, because you may land up with a complication at that one point of time. Second is, I run a small nursing home, so I realized that my table can't hold women more than 110 kgs. So, we've started a practice of getting our OT table serviced every 3 months as a routine, because I had a colleague whose table fell off with the patient on table. Thankfully, nothing happened. But then, this is a practical problem. And so this is something that I would just give a practical tip, that if you are in a nursing home or you're in a corporate setup, also make sure that the OT table is getting serviced regularly. And third is monitoring in the post-op period. We will operate, we do a good job, and you have a fantastic closure and everything is okay. But then that first 2 hours post-op, the consultant probably will not wait for 2 hours post-surgery. You're heavily dependent on an RMO who is going to be checking the vitals and telling you. So make sure that you're giving that handover. The nurses give a good handover, but doctors, unfortunately, we don't give good handovers to the RMOs there, that I want you to see the pulse, I want you to see the BP, abdominal girth, urinary output, and please call me at this time. Because for them, it is just an ordinary case. You know how much high risk, how much stresses you have taken to get the baby and the mother out safely.
Thank you. I think very valid point, Siddesh. I think these are the things which we talk about in this panel discussion, because we learn from each other the problems which we have faced, the challenges. Because it's very easy, like, okay, I've operated, finish line. Everybody sees the finish line, but how you reach to the finish line and what can be the problems between start and the finish line, I think very beautifully. I think I've also learned that yes, you have to service your OT tables, and I'm from tomorrow only I'll get my team to check it, that this kind of things do not happen. These accidents, I mean, this is an accident, should not happen in our operation theater. And of course, multidisciplinary team has to be there, and it has to be done in a place where they can hold everything all together, and all specialties are there. So, like, yeah, now carry on from here with what you
Suzette
have
wants to
about
say
the C-section.
Suzette wants to say something. She's raised her hand.
Yeah, yeah. And then I could see, yes, anybody who wants to ask, because, this is not something we are talking about, the theoretical or the points. What we are facing in everyday challenges, the problems in the north may be different in the south. So different kinds of problems we all have. So it's very, very fantastic platform to discuss and learn from each other. So if anybody has any point, they can bring it here.
Thank you everyone for getting all those points together. I just wanted to add, Dr. Archana and Siddesh, if you don't mind, few of the problems that we have had. And as you said, our OT table also broke. Even though we were using 130, okay, it actually collapsed below it. So our patient did not fall, but we couldn't use that OT for a long time. So currently we have one OT table that takes 180 kgs. And the remaining ones take about 300 kgs. So what we have is a setup, larger BP cuffs, video laryngoscope to be there when you are taking up these patients, because you never know what will happen. They have obstructive sleep apnea. Even during surgery, you find it. So wedges had to be created in our hospital to, put the patient. You couldn't make her lie down. There was no way you could make. So we had to create a lot of wedges to have that. The next one was stirrups. We couldn't put those women on those stirrups. We had to buy new stirrups. And I'm telling you, the maximum BMI I think we have done is 80 till now. Okay, and when we go to 180 kgs, it is very difficult to manage. So few things that each one of you can write it down and say that in addition to the table, BP cuffs are very difficult. Usually you don't have them, and then you struggle where to apply, how to apply. And sometimes if you are having that much of a problem, an arterial line, so that you have much better control, may be needed rather than depend on external part of it. The next one that I wanted to say before you go is, I usually do an assessment of the pannus. And if it is grade 3 pannus, that is extending below into the lower third of the thigh, then it is better to take a high transverse subumbilical incision rather than go into the pannus again. As Dr. Archana showed, you can lift up the pannus, but if the pannus is very huge, it is very difficult to put it up. I mean, you can take some kind of plasters as she showed, but some of the times the blood supply in that pannus gets obliterated for a long period of time, and you have necrosis of that area. We had 1 or 2 patients with necrosis also, because in the beginning we were. The retractors that we use are the Alexis retractor, 9 to 14 centimeter, or currently in India, we are also getting the MediSleep, which is much cheaper than Alexis, 8,000 versus 14,000. We should have one pair at any period of time in the OT, because you never know when you will land up into trouble. The next one, if I was just writing down the points to be added in, and I hope.
So nice that.
Yeah. So,
to
it will be a long surgery. So if the surgery goes 2 hours, then you have to, or if the blood loss exceeds 1000 ml, 1500 ml, consider your antibiotic dosage again at that point. Even the antibiotic dosage which you are going to give in the beginning is going to be much higher than your routine 2 grams of cefazolin or what. And the next one will be low molecular weight heparin, also has to be body weight based rather than, I also find it very useful to apply an abdominal binder, because this pannus is so huge. So immediately, at 6 hours, apply a binder so that the pannus is supported and the wound healing is not. So we have a multi-tailed cotton binder that we have created for these women, because of late 40 BMI is becoming very normal. Only we are getting worried with 50 BMI, but 40 BMI is becoming, every other person is becoming 40 BMI. Obesity is really increasing. So I just wanted to add those points in just to complete to all your points that you said. Thank you so much. I enjoyed hearing your case, Dr. Archana. I imagine what it must have been to do.
Thank you, Nuzhat, and very nicely you added few points. I think each one of us go enriched with one points, and we can really incorporate it into our practice, and we can really improve the outcomes and prevent the complications from happening. Thank you so much. Over to you, Siddesh.
Thank you, madam. I have divided the presentation into certain parts wherein we are just talking about the practical problems. It's not a case-based situation. So I would want the panelists to give their expert opinion on these clinical situations if and when they arise, because the topic is complication that we don't want in the OT. So we're talking about situations which are more of a surprise and some anticipated ones as well. Can you please play my point, please? Or should I share screen? I have shared my PowerPoint with you.
Sudeepji, I think, Sudesh, you shared it. Yeah.
Yeah, Sudeep is sharing.
Yeah, can you go to the next slide? We just come to the discussion because we've covered most of it. Just go on to the next one. Please come to the next slide. Next slide, please. Next slide. I'm skipping the social aspect and the demographic aspect of cesarean section. Please go ahead. Next slide, please. Next slide, please. For the next slide. Okay, here I want to ask the panelists, in difficult situations, how many of you are comfortable in taking a lower segment vertical incision in case the incision has to be taken? Now, there are certain situations like your lower segment has in certain situations where you are not comfortable in taking a lower segment transverse incision. Anyone who has an experience in taking a lower segment vertical incision? I haven't taken one in a very, very long time.
So hi, sorry, I could not join because there was some problem with my internet. So am I audible?
Yes, sir.
Yeah. So talking about the lower segment transverse, vertical incision, probably you're talking about the Leely's incision. Now I have had maybe 2-3 times I had to do it, but then I had a serious problem. The problem is that it extended downwards towards the vagina, and there was a colporexis also. So, and that was the most difficult thing to repair, because you cannot just repair from above. You have to go down below because it extended. It was an anterior extension that happened, and the urethra was involved. So it is a very, very difficult situation. So after that, I have never tried doing it. And what I do is, if it needs extension, I always prefer a J, and that works, because twice or thrice I had gotten into a problem with transverse sensation, but a J I thought was a much better way of extending.
Sir, J versus inverted T choice, J versus inverted T.
No, J will be better because inverted T has got a higher incidence of scar dehiscence and rupture in the next
Rupture,
pregnancy.
scar dehiscence.
Yeah, almost 9 to
Can we
10%.
move to our next slide? We come to the complications directly. Just skip a couple of slides. They will come to the discussion later. Okay. So here we are talking about the complications, difficulties in cesarean section and in the unexpected complications. Can we play it? It's an animated slide. Okay, so first thing that I want to discuss is a high floating head. Now, there are situations where the pelvis is contracted, borderline, the head is not engaged, and you anticipate that this is a high floating head. Many a times we feel that we are confident enough of taking a nice big incision on the uterus, putting your hand inside and stabilizing, decreasing the liquor, let the liquor flow, and then get the head out. But the head keeps rotating. So we haven't spoken to Jay. Uh, Ma'am, what is your take on handling a high floating head? Do you prefer to keep an instrument in hand like a forceps or a vacuum in all cases where you're anticipating a high floating head, or you're comfortable in gradually decreasing the liquor and then letting the head settle into your hand and then gently getting the head out?
So, good evening to all of you. I've been listening and it's been excellent discussion. So, floating head is a big challenge because now we have women who don't have the right contour. There's a big pannus, and you feel like that you're entering into a gutter to take the baby out, right? So, whenever I see a floating head, the first thing I do is I try to let the liquor come out very slowly so that if it comes out in a gush, there's a high chance that the head rotates. Also, I get my assistant to stabilize the pelvis so that the baby doesn't move here or there. And slowly, as we glide our hand, and most of the times you can see that the baby glides down with the liquor coming out gently, and you are able to deliver. One thing I never do is trying to give a fundal pressure from all sides. I mean, that's a big no for us, especially in this, as we were saying, social obstetrics, where the husband is also in the theater most of the times when we are operating. So I keep my forceps as a backup. Many times using it as a vectus works most of the times for me, but I don't mind using both the blades. If put in the right way, it works really well. Vacuum can be used. I have not used it. I've seen many people using it. I think it involves a lot of involvement of other people, unless you're using a kiwi or something where it's an handheld equipment, right? So, but I am very comfortable with my forceps, which I use as a vectors. I also put the other blade as and when needed. I think keeping your cool is very important because when everybody tries to push, the baby just rotates and doesn't listen. And giving fundal pressure from top, I have seen people just climbing up on the patient's tummy and giving fundal pressure. I think that's a big no for me because it really creates a lot of panic inside the theater.
Sometimes the
Completely
anesthetist
agree with.
giving the
Yeah,
fundal
yeah.
almost looks
I
like a
think that's very
CPR when they're
unfair.
giving
I think
fundal.
that's a
Actually,
very
it is so bad.
unfair way of doing obstetrics. We can do it much better, I feel.
Absolutely. And I completely agree with
Arnab
Dr.
sir.
Jayashree that, we have to keep cool because there's no point in hurrying here. Because, you have to be very controlled in releasing the lighter. The lighter. The other thing is in our hospital, we have always the outlet forceps in every cesarean set. It's there. So we don't know which is a high floating or not. You cannot anticipate in a big hospital. So every set has that.
Yeah.
Thank you, sir. We move to the next slide. Now, from the highly floating head, we are also anticipating a difficult situation where the head is deeply engaged. You have given an extended trial. She's gone fully dilated. You waited an hour. The head is nicely jammed into the pelvis. And I want the panel to let me have their experiences on how to deliver the deeply engaged head. I think I'm comfortable with Patwardhan technique. Anybody who wants to talk about the Patwardhan technique, Dr. Kavita?
Yeah. So I think Patwardhan and modified Patwardhan techniques both are like slightly different from each other. But what it essentially is, the head is deeply engaged. The only part that is visible is the trunk with both the limbs. So what you try to do is you try to access the limbs one by one, remove the breech, and then try to extract the fetal head. Sometimes, just sometimes, I mean, I don't know if this works for everyone, but in a deeply engaged head, I have done this a couple of times and it works. Slide my left hand under and then quickly hook the head with my right hand. And if it's not really, really bad, it really does help, instead of pulling the shoulders, because the chances of injuries do exist when you're trying to hook out the arms and the trunk and then the buttocks and then the head. The chances of injuries might be there, but this works occasionally and it has worked on a couple of occasions. So I do try to do that, disengage with my left and then try to deliver with my right. Slide down
Okay, madam.
across.
And I
Shruti,
think
madam.
here
Can I
again, as Dr. Jayashree said, not to be panicking, I think is very, very important. And having a head down would sort of help, because then, that also helps you. And I think the other thing is to release the pressure, because, when we go and the uterus is also going to contract down. And, that is going to be, and then we are fighting against a contracting uterus. So I think waiting for a while and then letting the pressure go. And as Dr. Kavita said, doing it with the left hand and maybe having a step stool so that we can go at a height and then do it. And the other thing is not to have a nurse pushing in, because many a time, we are in a very difficult situation. We ask the nurse to push. We have had couple of skull accidents in
There.
UK where, we have had major issues. If you want to, I think as an obstetrician, if you have done a difficult trial, maybe gently pushing the head before we, sort of go to the abdominal incision. But I think that is very, very important, not to get an untrained person pushing on the head. And as Dr. Kavita said, Patwatan is good, but I have had funny neonatal colleagues saying, what is the way that you're delivering the baby? And in UK, they went into a sort of a shock when they saw the baby coming that way. Reverse breech also works very well. If we can, sort of go in and have a bit of a space, that also works well. We did have fetal pillow in UK, but I know that it's gone out of favor, and I don't think it's a major kind of a use. Though, in India, there are a few people who are thinking, it's a big boon, but somehow it is not. I don't think we need to go that extent to use a fetal pillow. Patwatan is very good, but of course, gently, pushing the head if you've done a difficult trial, so that you make it easily accessible and you know how much you've pushed it.
I think in
So
Patwardhan,
one
the
thing,
back
sorry.
anterior. Yes, sir, you can continue.
Yeah, one thing I wanted to tell here is that Patwardhan, if somebody has been trained in that, because unfortunately we don't get to see too many of deeply engaged, which are really deeply engaged. Because in a very deeply engaged head, there is no way you can even insinuate your fingers. So that is the way things are. So here again, the access is very important. That is what I wanted to say. And probably this is where your J incision will come in very handy. That's number one. The second thing is that we lose track of the shoulders. That's first thing that we should do. That the anterior shoulder anyway will be seen, but then when you just try to turn the shoulder a little bit, and the posterior shoulder also gets hooked out.
Visible.
And that is where, when the whole principle is bending the trunk upon itself and trying to deliver the part of the shoulder and the thorax and the abdomen slowly and progressively. So when you try to do that, what you have to do is you have to release the shoulders, which we sometimes, lose track of that. So once the shoulders are free, then the part of the body which subsequently comes out becomes easier. And that is what I have seen most of the time.
Sure, here I would like to add that when the first shoulder is out and the second shoulder is out, you're holding onto the trunk. There should be a little fundal pressure given so that that buttock gets a little disengaged. We'll end up pulling with too much force, and that's when the complication happens. Just a little bit of fundal pressure, the breech comes out, and then the head comes out much easier than probably trying to put your hand in, because those extensions are very bad to suture, and it could lead to a disaster. With back anterior, I think it is easier. With the back anterior, it's easier. With back posterior, it becomes a little more difficult because you get one hand and one leg out, and you try and keep the back anterior and still go ahead with this maneuver. So, thank you for this Wonderful insight, all of you, on Patwardhan.
Dr.
Just a
Sudesh, can
picture.
I add one thing here?
Yes,
See,
madam.
when the head is engaged, there's a tendency for people to give the incision lower down. Actually speaking, the incision should be slightly higher on the lower segment, and it should be curved upwards, not downwards, because that is where you cut through the descending cervical artery. So if your incision is higher up and you go low down, your chances of tearing is much lesser, even when you're trying to manipulate the head and rotate and take it out, I think. And that should be an added point for everybody, because people usually give the incision lower down and then they struggle because you enter the descending cervical and you're bleeding and bleeding there. So the incision should be slightly higher up on the lower segment, even if it's a deeply engaged head.
And
Ma'am,
also,
here I
I would
want.
like to just add one more thing. I'm not very, like, when I was trained in Mumbai and when I was working as a lecturer in Pune, where we had no PG students. So it was just as a lecturer with some SR who was not very experienced. So 2-3 times I tried doing a very deeply impacted head, just a PV, and tried to push the jammed head. And it has really helped me that time. Because when we were while in PG training, we had your seniors, your SMOs, your lecturers, everyone is there to support you if you're in panicky mode. But when you're at night, when there is nobody and you're the senior person on floor, so this has helped me. And one thing which is controversial, which the anesthetist does not like generally, but sometimes we can request for a GA because it will relax the tone. Obviously, we have to weigh in the PPH, which can add up. But just if it is very jammed and we do not have any option, we can ask for it. And if they're reasonable enough, they can give that.
Well taken point,
I
madam.
think one
Uma
point here
madam,
is
you have raised your hand.
instead of GA, I think we could give terbutaline rather than
Yeah.
resorting to GA.
But
Because
ma'am,
that would
generally
also help relax.
generally in India, they are not very pro for giving all these things. Like, they have inhibition. Like, you have to fight a lot to ask. They're like, no, spinal. So that is one.
Yeah, just I would like to, reiterate what Dr. Jayashree said, no, that make an incision a little high up, because sometimes when the head is jammed down, no, you may get into the vagina and take out this, what is called as a laparoerythrotomy, and you cannot find out the cervix. So it may be a vaginal type of cesarean section through a vaginal incision. So taking a higher incision is always better in a deeply engaged head. And we have done many reverse breaches rather than Patwardhan, and it works very well, except in cases where the liquor is already drained, because she's in prolonged labor. We may not be able to insert our hand inside and catch hold of the foot and bring down. So that time, a little bit extension, that in J-shaped incision definitely helps. We can put our hand very well inside, but not to panic. Definitely, we can bring out the foot. And if you catch one foot, it's enough. If you give gentle traction, without fracture, we can bring out the other foot and then deliver. So that reverse breach is also a very good technique, and it is not at all frightening. It can be done very easily.
I think for as surgeons, before taking the incision, the most important thing for us is to count 10 up to 10 and take a deep breath and then start the surgery so that everyone is sorted.
I think this is a very valid point, that before you're entering into surgery, it is better that you're mentally ready with plan A, plan B, plan C, rather than thinking on the go. Because if you know that the head is deeply engaged, you've done a PV and you can't even feel, you can only feel the shoulder, you know the shoulder is going to come in the incision. You have to be ready that, okay, am I doing Patwardhan? Do I have somebody to give me counter traction? Do I have the adequate resources? Or should I call somebody to push it from down? So that mental preparation probably will help in reducing the complications. Dr. Alia, you want to say something?
Yeah, I was just trying to reiterate that Patwardhan really works. If you're trained to do Patwardhan, and where I work in in the place that I work in this part of the world, actually they have heard about Patwardhan, but nobody is trained to do Patwardhan. And doing a second stage cesarean is really a nightmare. So I wanted to add the point of taking the incision up, like slightly up, and a smiley incision, so that you don't go into the lateral, you don't go into the uterines as well. And also the Patwardhan never fails you. It really prevents that bad suturing in the end, and the bad tear. And anyway, the mother is exhausted, it was prolonged labor, the liquor is already drained. So this is one technique which never fails you, and it actually surprises many of your senior consultants, because actually they don't do it and you're the one who is doing it. So that's one thing. Another important thing I just wanted to add, I think it was missed, is the recent guidelines about azithromycin 1 gram. So for rupture of membranes or for unscheduled cesarean section, apart from 2 grams cefazolin, we need to add azithromycin as well. So that's about it.
I think we can move to the next slide. We are already running beyond our schedule, so we will run through the few slides next. Go to the next slide, please. Okay, so now one take home points probably on extensions of the incisions. Any particular tips and tricks for the audience that if you feel that your incision has gone extended, it's gone behind, it's more of gone to the posterior surface. When you try to extend it with your fingers, you realize that that one angle is probably on the posterior aspect. Uh, can I have Srimati Madam giving expert advice?
Yeah, thank you. So I think it's important that we identify. I think that is very important. And of course, now the bleeding, because it's in the angle, you're going to have bleeding as well. So whether when you have to secure the uterus and then have an exposure, whether you want to exteriorize the uterus, because then you will be able to identify it properly, and also to control the bleeding, because there's going to be profuse bleeding because it's an angle. So whether we want to take the uterine so that we would be able to at least identify it, and of course, be very careful because it would have gone into the broad ligament as well. So whether the ureters are coming, so those are the aspects which we would need to be careful about. And of course, if you are a junior, then making sure that we have a senior who's on standby, because this is where you will be probably going into the broad ligament, and the hematomas can spread even into the retroperitoneum. So you need to be very careful, having clear exposure and having some technique in order to control the bleeding before we can clearly identify and suture.
Thank you, madam. Arnav, do you,
Yeah.
Dr. Arnav, do you
Oh.
regularly exteriorize the uterus in all cesarean sections, or you think, I mean, you keep the uterus inside and suture? Because as madam put it, certain cases it will give you better vision, but then more often we keep the uterus in and suture. So in this case, you think it would be wiser to get the uterus out in difficult situations and check everything properly before closing and calling it that you've done a good job?
Yeah, so most of the times, if it's a very uncomplicated case or an easy case, you can keep the uterus inside, no problem. But if you think that there are bleeders and if it's a complicated case, removing the uterus is not an issue. Yes, there is a slight chance that there may be a atonic uterus, which everyone has faced, but it's not never really translated into a massive atonic PPH or something if you remove the uterus. So the main thing is to get the suture line properly sutured, have a good reinforced suture line, identify the bleeders and take it. Another thing that I want to add is, after seeing Dr. Mahesh Gupta's amazing, surgeries, something that I do is for every complicated case, I really dissect the bladder, because I put a myometrial transverse suture down as well as up, make sure that the descending cervicals are well taken. Even a uterine artery, if it needs to be ligated, it can easily be taken if your bladder is very well pushed down for any severe PPH management. So you're sorted in terms of major arteries. But you can put the uterus back in. The only problem is if there are many adhesions, then what do you do? So you have to know how to suture if the uterus is inside. So you have to be comfortable with both techniques, basically. That's the main thing.
Arnab sir, you want to say something?
So, yeah, I wanted to emphasize this point that, exercising the uterus, I do it in every case, because there is enough of evidence to say that even if you exercise, there is nothing else other than the little bit of discomfort and little bit of nausea. Sometimes the patient might complain of. But then, very importantly, when you have this extension of, and especially the posterior extension, you have to exteriorize and you have to see the extent. And then sometimes, the bowel also may get involved. So you have to check the bowel. This is very, very important point. The other thing is when the extension happens is basically because of the tear. It's not a sharp cut because why it happens. And so when there is a laceration of the uterine, initially it may go into spasm and you may not see any bleeding. But then when you have sutured and you have missed checking about the hematoma, it can happen in the post-operative period that you suddenly realize there is a broad ligament hematoma. So you have to make sure that you have secured the uterines, because uterine has to be ligated in every case of lateral extension.
Point taken, sir. Can we have a next slide, please? Okay, I think lacerations we've already covered. I think even Basir madam covered lacerations. We'll skip this. We'll go to the next point. Okay. Next point. Two more slides. Okay. So here we spoke about the injury to the bowel in case of posterior extensions. Difficult deliveries may also have injury to the bladder and the ureter. So I think we should take putting in a Foley's probably is a good idea because it will give you an idea in such situations. But sometimes what happens is if your head is very low, it is very difficult to pass a Foley's also, and you already have hematuria flowing in the moment you started your C-section. So hydrating and then you keep an eye for a bladder or a bowel or a ureteric so that we have not missed this complication. Next slide, please. Okay, now just a few one-liners. So if you have a difficult entry into the abdomen, like Archana madam's case had, that you had previous 2 surgeries, previous laparotomies, any particular tips from the panel that how can a fresher or a newcomer tackle those tackle those situations so that entry to the uterus is clean? Sometimes the entry to the uterus is so bad that the rectus is completely plastered to the anterior uterine wall and you have no access. There are times when you've taken an incision and you're already inside the uterus. So from the expert panelists, maybe can we have like one liner on how to tackle these adhesions?
So when you have when you're anticipating adhesion, especially because of prior surgeries, it is better to avoid the previous scar lines and try to go as laterally as possible through the relatively virgin area. So you have to, those certain principles that, peritoneum, feel for it, pinch the peritoneum between your two fingers and then try to feel for it. If you feel that it is too thick, you avoid those areas. So it could be bowel, there could be bladder there. So you try to go more laterally towards the relatively virgin areas, and then that is where you make the entry. And always empty the bladder before you enter, because many a times it happens that the bladder is relatively full. Even if you have put in the Foley's, you have not taken care to drain the bladder completely, and you have gone directly incision into the bladder.
So my take on this, Dr. Jayashree, here is that whenever you see yellow, hold your scalpel back, because yellow, dirty fellow means bladder is very close by. So go above, then below. So many a times when you have midline scars before and you're doing a phalansteal incision, you see parietally, at the parietal peritoneum, the bladder is very high. And many times you end up opening the bladder thinking of you're opening up the parietal peritoneum. So I think this yellow sign we should all remember. I mean, this one thing we should all keep a note of. I have been trapped before, so I'm very careful about it. So this is one tip everybody should learn.
Kavita,
Hi.
you want to say something?
Yeah, so I think the one thing that I would do is review the notes of the previous surgery if I have access to it. I think it helps you prepare yourself better if there were any adhesions, any complications, what was done. And if there are some people who actually diagrammatically represent, it makes your life a lot easy. So I think go back to the history, go back to the notes, and it might really help you in placing your incision. The other thing is that go plane wise, go slowly, use sharp dissection, don't use blunt dissection when it comes to these, and be very, very careful, because we've had cases where the bowel is so badly adherent to the rectus and the muscle that you think that you're opening the rectus and there the bowel lies right in front of you. So I think following basic principles and going layer wise and using sharp dissection should help you most of the times. If it's still adherent, try to go laterally. And if you think that it's going to be really difficult, call for help beforehand. It's always better to be prepared than to make somebody rush, and always have a surgeon on standby if you anticipate adhesions which cannot be tackled by you.
Uma
Yeah,
madam,
I
you want
think
to say?
here, can I just add one? I think I agree with Dr. Jayashree, because we recently had come across a case where a similar one, where the bladder was transected through and through. So I think this is something which we need to be very careful about, because going as high as possible, and as Arnab sir was saying, going to a virgin area, because otherwise, as Dr. Jayashree said, we think we are going into the peritoneum, we keep opening the bladder, and then, we are completely lost. I think that is very, very important in respecting the tissue planes and identifying them before we actually make a cut. And maybe using sharp and not using diathermy as well, because we don't know where the bowel is, and we inadvertently cause electrical damage as well.
Yeah. Well, I just wanted to add that if sometimes the uterus also will be stuck anteriorly, very close to the peritoneum. So I always found that cutting the rectus muscle, that is a Maillard's incision, no, you will definitely find laterally when you cut the muscle, very good space where there are no adhesions. And then under vision, you can dissect and then come medially. Definitely, I think we can avoid a lot of injuries to the bladder and the bowel. So Maillard's incision works very well in previous 3-4 cesarean sections when there are
Thank you,
lots
ma'am.
of adhesions.
Suppose you have opened up and you find place that you can put an incision on the uterus and take the baby out. Do you enthusiastically go and still separate the adhesions to make everything right, or just get the baby out and finish the cesarean section where you are? I came to do this, I did this, I finished off. What is
Just
the
get the
take of
baby
panel?
out. Just
Baby
get the baby out. You'll get into more trouble than you can imagine. Just get the baby out. And
Sometimes the
then once the baby's
enthusiastic
out,
surgeon in you wants to, put everything back into place, keep the rectus back into its position and get the bladder sorted.
No, adhesiolysis is last.
after the baby's out, yeah, I think.
I think we will just take one more situation, because otherwise our situation can go out of hand, because we have so many complications to discuss that the topic can be never ending. So here, just last thing. Now we are seeing so many previous cesareans and previous 2 cesareans that there are situations where you've seen a bad NST and you probably are expecting that there is a scar dehiscence, but then suppose you're like seeing a rupture. Now, in this situation, we have all senior experts on the panel. I would wish the senior experts to give us tips on how to manage a rupture in case you are seen a rupture, either complete rupture or a partial rupture, and your take on suturing the rupture versus considering an obstetric hysterectomy, and if at all a obstetric hysterectomy, then how can we quickly finish the obstetric hysterectomy? We will stop at this at the end of this situation.
To begin with, see, the thing is, when you're talking about partial rupture, it happens, we have seen many times. So, but the peritoneum is still there attached, and you can see the lica through it. So these are win-win situations. So all you have to do is deliver the baby, refreshen the edges, and then suture it. And you really don't have to do anything much. But then the question is that if you have rupture, and how bad is the rupture? The worst ruptures are non-scarred uterus.
Yes.
And that is where whatever you do, I have failed, to save, because it burst. It just burst. You are not able to put pieces together. And that is where you have to do the obstetric hysterectomy. And it is a 2-clamp hysterectomy. You just put 2 clamps, take the uterus out. Don't bother about whether it is subtotal or total, because you will not have much time, to even separate the bladder, because if it's an old rupture, you will have edematous bladder and edematous tissue. That is what I have seen, and it bleeds horribly to touch. So finish the hysterectomy as quickly as possible with 2 clamps in the uterines, and then once you've done that, then you do the other clamps and take it out. Because as I said, that old ruptures are really bad. I mean, only in the sense that neglected, of course, obstructed labor, and then the patient has been. We have seen many such cases, in the rural areas. So I think that is why we have to be very, very careful.
Can we have one take-home message from all our panelists on dealing with complications in a cesarean section? One expert piece of advice that all the juniors who are watching will keep in mind, that this is what we learned today. We start with Dr. Richa.
I think basic understanding of the anatomy is very essential, first of all. And what I always believe is, please do not panic and go with a cool mind and preparedness. Like plan A, B, C should definitely be in your mind, always. And
Thank
ask
you.
for
Dr.
help.
Arnab?
Please do not hesitate and do not feel shy.
Dr. Jayashree here. I think build a team, work with the same team, have a protocol set in OT, so that everybody follows the same guidelines. Many times when you're changing teams, or when you're changing, so the protocol is fixed, then your team works in the same way. I think that makes a big difference to have a stable OT.
Very well said, madam. Dr. Srimati?
I think, as we already discussed, anticipation and being prepared, and also thinking about the unexpected situations, because that is when we get, caught unaware. So I think being prepared for every situation, even if it's a straightforward elective cesarean section, we never know where we are going to be getting caught. So I think always being prepared, and as I think, as Dr. Richa said, maybe having a team huddle so that we are all calm before we start. May not always happen in an obstetric emergency situation, but wherever possible, I think that's very, very important.
Dr. Arnav?
Before every incision or every knot, just think twice, assess, analyze. You have to think within those microseconds. So make sure you do that and only then proceed, and don't be afraid to ask for help at any time. The patient outcome has to be good. So.
Right. Dr. Alia?
Most of the panelists have covered everything, but I would say that the counseling part is extremely important. In today's days and time, with a lot of litigation, and also when patients are very educated, they are advocate of their own health. Even if you do everything perfectly and you feel you did a great job, they still would have some complaint. So I would say that apart from the rest of the things, patient counseling and informing them and keeping them in loop about everything, especially about these high risk cases, and also about the usual cases. Keep them on board, inform, educate, everything. If unexpected complications happen, they will still be on board with you because you were honest to them.
Arnab sir?
So I think everybody has covered everything except one thing. This consenting is very, very important. And I think as a surgeon, we have to do it by ourselves. Don't delegate it to the junior most member of the team. That's number one. The second thing is, after having finished a cesarean section, the next 2 hours is the golden time, which sometimes we just ignore. We delegate it again to one of the junior most team member. This is, I think, one area we have to work a lot on it. Even in our hospital, we have seen, I have done the cesarean section. I have told them that please keep a watch on this patient. And, all they did is just went after half an hour, just written a sketchy note and come back.
Dr. Kavita?
So I think it's the difficult cases which you're always prepared for. If you have a preeclampsia, you have a diabetic, you're prepared, your team is in place. What catches you off guard is a low risk simple patient who you'll shift and you see her in half an hour and she's had a massive PPH. So I think always anticipate in obstetrics what complications could be there. And I cannot emphasize enough the need for those first 2 hours of monitoring. I think we always keep them in the SICU, watch them. A senior person comes, watches for the bleeding, analyzes the urine output, checks all the vitals, and only if they're convinced that she's apt to the room. If we slightly feel that it is not manageable, she stays in that monitoring place till the next morning, till somebody senior enough comes, assesses, and shifts her. So I think always anticipate, because it's the low risk cases that always catch you off guard rather than the ones that you're prepared for.
Archana ma'am, your take on the difficult situations in cesarean section.
Can I add something?
Yes, ma'am. Yes, ma'am.
I think I really
Waiting for your expert advice.
really enjoyed the panel. Everybody has covered everything so beautifully. I just want to summarize or maybe say one thing only. In obstetrics, najre hati, durghatna ghati.
Yeah.
You have to be always observant, and you always have to be on guard. As Kavita said, low risk takes you always,
By storm.
Yeah.
I think a small prayer before every complicated case takes you through. I think somewhere in the end we are praying that chalo shanti se nikal jana chahiye.
No,
This
but
is-
you still end up in something or the other. That's obstetrics. I think it's just the way it is. I don't think you can ever be too prepared, or no prayer is strong enough to tide you over a lifetime of obstetrics.
And make
I think
sure
one
your
more thing is, I think we spoke about.
your indemnity cover, is there on otherwise you forgot to renew it. So
Yeah.
be careful with that also.
That's true.
I think one point is, we spoke about so many things, but WHO checklist. I think the surgical safety checklist, pre-op, intra-op, post-op, I think that is very, very important. And that will be our prayer. I think that is what would save us, because all of us are on the same page. I think that is very, very important.
I would like to say, whatever be the seniority, every cesarean, consider it as your first case. Take the same interest and take consent, as Dr. Arnab had said, and follow all the protocols. And then write the notes, whether it is, even if it is written by a junior, always counter check whatever the problems. And I think keep everything ready on the table. It may be not a very mobile head, but still keep everything. And for PPH also, I think that consider it's a first case you're doing with the same case care, you should do all the cesareans, whatever be the seniority.
Thank you, all the panelists. Thank you, my co-moderator, Archana Madam. Thank you, Anju Madam, for having us to conduct this panel. I think I hand over back to Dhwani to take the further proceedings. Thank you, all of you.
Dr.
Thank
Siddesh, you have done a wonderful
Thank
job.
you so much.
Thank you.
Thank you. Thank you. Thank you, everyone,
Thank
for
you.
Thank you
being
so
here.
much.
Thank you.
Thank you.
Thank you so
And
much.
I'm looking forward for your support and vote for those who have not voted. Still, there is a time to vote.
All the best,
Thank you.
Dr. Archana.
All the best,
Thank you
ma'am.
so much.
Thank you. All the best.
All the best, ma'am.
Thank
All
you.
the
Thank you
best.
so much.
All the
So,
best.
all the best, ma'am. And thank you so much. And thank you, Siddesh sir, for moderating this beautiful discussion. And thank you to all our panelists, because this has been quite a stimulating discussion and wonderful learning experience for all of us. So as we come to close this enriching academic webinar, it is my privilege to thank one and all of you once again. I'd like to extend my heartfelt gratitude to our chief guest, Dr. Mahesh Gupta sir, our guest of honor, Dr. Nazat ma'am, for her gracious presence. And I would also like to thank all our distinguished speakers, Dr. Vidhi Chaudhary and Dr. Mallikarjun sir. I would also like to thank our chairpersons, Dr. Anju Hazari and Uma ma'am. And I would also at this point extend my sincere gratitude to again our moderators and the panelists for this amazing evening. And while my sincere appreciation goes to our conveners, Dr. Anjum Said and Dr. Manila Kaushal, for their vision, leadership, and meticulous planning in bringing together, I think, doctors from across our country, and we do have someone outside our country too. And this has been an outstanding academic program. We would also acknowledge and thank our academic partner, Pharmed, for supporting this educational initiative. And sincere appreciation to Mr. Sudeep and his entire team for the seamless coordination and flawless execution of today's webinar. Finally, I'd like to thank each and every participant for joining us this evening. Your enthusiasm and learning and commitment to advancing women's healthcare are what makes such academic interactions truly meaningful. So with that, I think we'll conclude today's webinar. Thank you all, and wishing you all wonderful evening ahead.
Thank you, Dhwani, for being the MOC. Thank you for conducting the whole session.
Thank you. Thank you so much.
Thank you,
Thank
Dr.
you. Thank you, everyone. Thank you, Dhwani. Thank you, Anjum. And thank you, Sudeep ji, for providing the seamless platform here. And I think bye-bye and good night and a good weekend to all of you.
Thank you. Good night.
Thank you. Good night, ma'am. All the best.
Thank you,
Thank you.
dear.